Hello and welcome to this Physiology and Imaging update. I'm Arnold Seto from the Long Beach VA Medical Center. These are my disclosures. In 2020, we have myriad options in invasive coronary physiology, from the original FFR to now the non-hyperemic pressure ratios, including PDPA, as well as all the subcycle branded versions of DPR, including IFR, RFR, and DFR. Because of all these options, perhaps, the current state of physiology in the US is reasonably good, with 25% of all PCIs undergoing some kind of physiology measurement. PCI of stable intermediate lesions reflects an even better uptake of this evidence-based methodology, with about 69% market penetration according to Philips. Similarly, Bill Fearon found in the VA population that FFR was used in 75% of cases of PCI of intermediate lesions, and that the use of FFR was correlated with a reduction in all-cause mortality. FFR can also be estimated from angiographic imaging. In this meta-analysis of 5 studies of the CathWorks system, the correlation between wire-based FFR and FFR angio was 0.83. Non-invasive assessment of coronary hemodynamics is alive and well with FFR-CT, the most recent data of which, from the advanced registry of 5,000 patients, showed that an FFR-CT value of less than 0.80 was prognostic, similar to an FFR value. This is prognostic for MACE, death, or MI. FFR-CT is reimbursable by CMS, and there's some ongoing controversy as to whether wire-based FFR will be reimbursed following an FFR-CT. Combination catheters remain a topic of innovation, with the combination IVUS-OCT catheter from Coronary Medical already being on the market. James Muller has developed a combination OCT near-infrared spectroscopy catheter, which may enable us to have both anatomic and pathologic data in a single run. Another innovation is that FFR can be derived from anatomical data, especially from OCT data. In this study published last year and presented at EuroPCR, they found that the correlation between OCT-derived FFR and FFR was reasonable with an R value of 0.84. And it was superior to OCT MLA for predicting an FFR of less than 0.80. So the use of anatomic data may enable us to get some kind of estimate of physiology. In terms of clinical trial results, I'm just going to highlight 3 recent clinical trials. The first is the Illuminion 3 clinical results. If you recall, the Illuminion 3 trial randomized patients to either OCT, IVUS, or angiography-based PCI, and in this study they found about 150 patients in each arm. The procedural endpoints from this trial have been previously presented, with OCT and IVUS as expected, resulting in a larger mean stent expansion, and as well as a reduction in any dissection or malapposition. These procedural results would have been expected to reduce clinical outcomes, but at least in this underpowered analysis, there was no difference in either target lesion failure or MACE rates between OCT, IVUS, and angiography. So we'll need to await the results of Illuminium 4 of about 3,000 patients before we'll be able to conclusively determine whether OCT and IVUS have superiority over angiography-based PCI. The DEFINE PCI trial was presented last year at the ACC, and this was a study of the potential value for post-PCI IFR. They took patients, 500 patients, with successful angiographic PCI results, and then we had patients undergo a blinded IFR pullback, followed by guideline-directed medical therapy and 30-day, 6-month, and 1-year follow-up for anginal symptoms. Given the frequency of post-PCI residual angina, it's not surprising to find that 24% of patients still had an ischemic IFR of less than 0.89. And of these patients with residual ischemia, it was estimated that 80% of these had focal lesions that potentially could be resolvable with additional stenting. This could occur within the stent itself, which could potentially be expanded further with post-dilatation. Alternatively, there was lesions that were more proximal and missed by the original stenting, and this constituted about 1/3 of cases. And distal lesions, distal to the stent, also constitute another 1/3 of cases. Theoretically, if you treated all of these lesions, then you could reduce the incidence of post-PCI angina down to about 5%. This suggests that post-PCI IFR or FFR has value and could potentially remove the risk of missing a hemodynamically significant stenosis. The most interesting trial straddling physiology and imaging was the FORZA trial presented at TCT last year. This took 350 patients and randomized them to either FFR guidance, both pre and post-PCI, or OCT guidance, both pre and post-PCI. In the FFR guidance arm, following PCI of an appropriate lesion, the FFR was measured and additional stenting or balloon angioplasty could be used to achieve a post-PCI FFR of greater than 0.90 as the goal. For OCT guidance, the area stenosis of greater than 75% or with other factors of greater than 50% was used to determine lesion significance, and then after PCI, optimization with OCT occurred with minimizing major stent malapposition and underexpansion or edge dissection. Patients in the FFR arm had lesions deferred 71% of the time, whereas in the OCT arm, patients were deferred only 50% of the time. Patients with OCT-guided PCI required more contrast media for their procedures, with attendant increases in the risk of contrast-induced nephropathy, up to 8.6% compared to 1.7%. However, this did not seem to affect the results negatively. In fact, the OCT arm showed a numerical reduction in major adverse cardiovascular events at 13 months, with a higher rate of failure, especially of the target lesion, in the FFR arm. The combination of MACE or angina at 13 months, which was the primary outcome as well, showed that the FFR arm had a higher rate of MACE or angina compared with OCT. So whether the FORZA trial demonstrates that OCT can adequately substitute for FFR in lesion assessment, or whether FFR post-PCI is merely inadequate to make up for the stent optimization qualities of OCT remains to be seen. In this editorial accompanying the FORZA trial's publication, Dr. De Bruin and others put together all of the combinations and suggest that optimal PCI requires all of the above: a pre-PCI FFR, a pullback, imaging, as well as post-PCI imaging and FFR assessment. Thank you.